Welcome to Collaborating with State Medicaid Programs on Guidelines, Based Asthma Care Coverage. Before we begin, as a reminder, at the bottom of your screen there are multiple application widgets you can use. All the boxes are resizable and movable, so feel free to move them around to get the most out of your desktop space. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in background that could cause issues. For the best audio quality, please make sure that your computer speakers or headset are turned on and the volume is up so that you can hear the presenters, and make sure the media player on your screen is enabled. If you have any technical difficulties during the webcast, please let us know via the Q&A box. If you have any questions during the webcast, you can submit them through the Q&A box. The webcast is being recorded and will be available tomorrow and can be accessed using the same link you used to register. And now we'll begin the webcast, and I'll turn the call over to Hannah Green, National Director for Health Policy for the American Lung Association.
Thank you, and good afternoon, everyone. We're really excited to have everyone here with us for our webinar today and to discuss some really exciting work we've been doing as part of the Asthma Guidelines-Based Care Coverage Project here at the American Lung Association. We're really hopeful that the work we've been doing over the past year, looking at some of the incredible work that state asthma programs and state Medicaid programs have been doing together to improve access to guidelines-based asthma care for patients with asthma, will be really helpful to the work that you all are doing across the country to improve access to guidelines-based care. So let me first just briefly say that this presentation is made possible by a grant funded by the Centers for Disease Control and Prevention. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of the Centers for Disease Control and Prevention or the Department of Health and Human Services. So just let me briefly say, for those of you who aren't familiar with the Asthma Guidelines-Based Care Coverage Project, we launched this project in 2015 with funding from the CDC. And each year, the Lung Association tracks coverage and related barriers to guidelines-based asthma care in every state Medicaid program. The medications, the services and treatments that we track, and the barriers to care, things like copays, prior authorization, step therapy requirements, are all based on the NAEPP guidelines, which, as many of you know, are in the process of being updated. The objectives for this project are to increase the understanding of Medicaid coverage and barriers to access guidelines-based asthma care across all 50 states, DC, and Puerto Rico, to identify gaps between what is known to be best practice in improving asthma outcomes and what is covered by state Medicaid programs, and finally, to promote collaboration between diverse stakeholder groups to increase access to guidelines-based asthma care. And I think that third point is what we're really going to be focused on today, to highlight some of the really important collaborations between asthma programs and state Medicaid programs and see what lessons learned can be shared with all of the stakeholders on the phone today. So briefly, after I finish up my introduction, we're going to talk about a new report that the Lung Association released today, Advancing Guidelines-Based Asthma Care, Collaboration with State Medicaid Programs, which you should all be able to access from the Resources tab of today's webinar platform. So we're going to go through some of the key findings from that report, and then we're going to talk hear directly from two states that participated in the work group that led to the development of that report. Folks on the phone from Missouri and Montana's asthma control programs, who are going to share some really exciting insights from their work working to improve Medicaid coverage for asthma patients in their state. Finally, we'll go through just a quick overview of some of the other project resources that we have available, and then we'll leave plenty of time at the end for questions. So feel free to chat questions into the Q&A box as we go through the webinar today, and I will make sure that we get those answered at the end. So with that, let me turn things over to Katie Horton, who is a research professor at the Department of Health Policy and Management at the Milken Institute School of Public Health at George Washington University, who led the work group that developed the report that we're going to be talking with you all about today. Katie?
Great. Thank you so much, Hannah, and good afternoon, everyone. Many thanks to CDC and the American Lung Association for supporting this work. Much appreciated. You know, I think this project came about because a number of grantees and other stakeholders actually were asking, you know, what's the best way to collaborate with the state Medicaid office? How do you approach them? How do you start that relationship? how do you really advance your work around guidelines-based asthma care with Medicaid? So ALA and CDC convened a number of NACP grantee leaders to share their observations in this area. So the real purpose of the project was to have these grantees talk about their best practices and lessons learned from their experience engaging with their state Medicaid programs. Just by way of background, as many of you know, NACP funds health departments in 24 states and in Puerto Rico to ensure availability and access to guidelines-based asthma care and pharmacotherapy. NACP grantees address the intersection of public health and healthcare through a host of activities, including home asthma trigger assessments and remediation, asthma self-management, education, and many other initiatives. When we talk about guidelines-based care, it's really referring to the best practices in asthma management. These are identified by the National Heart, Lung, and Blood Institute and the National Asthma Education and Prevention Program. And these guidelines focus on 4 primary areas: assessment and monitoring of patients with asthma, education about asthma self-management, control of environmental exposures that affect asthma, and medications to treat asthma. So there were 4 NACP grantees that came together to share their perspectives. Folks from Missouri, Montana, you'll hear from today, Rhode Island, and Wisconsin. Many of these grantees had focused on improving coverage of home-based asthma services, as well as encouraging overall compliance with asthma guidelines-based care. So in terms of the project, we brought these 4 NACP grantees to discuss a variety of topics, and they did that over 4 group interviews conducted between March and June of 2019. The conversations we had with folks focused on stakeholder education and consensus building, relationship building with state Medicaid offices, use of Medicaid claims data and quality metrics, Medicaid coverage reimbursement for asthma services, and tracking utilization and evaluating progress. We'll share some of our key findings with you today. The first is really understanding Medicaid. For many grantees, although they had interacted with Medicaid programs throughout their careers, they noted that sort of learning the language of Medicaid was important and could be challenging. There are so many programs within Medicaid, initiatives, and acronyms used, so really being familiar with the program in their state and practices seemed to be super important to them. So being able to speak fluently about the state Medicaid program would help facilitate more effective conversations. So in terms of mechanisms for coverage, you know, each Medicaid program is so unique, and knowing the specifics of your program will really dictate the pathways for coverage as well as the potential barriers to expanding the policies you want to achieve. So thinking about a number of questions, like what's been the state's willingness to expand optional Medicaid services to address the needs of beneficiaries with specific types of chronic health conditions? How are most Medicaid beneficiaries in the state served? Are they served through managed care organizations or through a fee-for-service program or a combination? Within these programs, what are the specific delivery and financing systems that might be used to address guidelines-based asthma care? And does the state operate under current Medicaid waiver or some other health reform initiative? There's so much creative work happening in the states now, and really understanding the greater context of health reform in your state is real important. Another primary point of discussion among grantees was, at what point is it helpful to engage a broader coalition? Is it better to bring that coalition in and together before approaching Medicaid, or is it better to do that after you've had your first interaction with Medicaid? A grassroots coalition can show power, but can also detract from the goal of, requesting a specific ask from Medicaid. And so some grantees noted that just going in with a few partners may be more effective than a broader coalition. One participating grantee initially worked with a variety of patient organizations, noted that while their coalition presented a powerful case, negotiating consensus among all of the parties actually slowed down the process. So in this case, they recommended actually narrowing your group of stakeholders before approaching Medicaid, and just identifying a few key people who could speak with some authority on the policy being discussed would be helpful. Regardless of when a broader coalition is being engaged, grantees all agreed that ultimately having that broad base of partners is very helpful to advancing guidelines-based care for asthma. They noted a number of coalition members that are important to include: healthcare providers, pharmacists, asthma control professionals, hospitals and hospital systems, school nurses, health department officials, and certainly representatives from any managed care organizations in your state. So much of care for Medicaid beneficiaries being done through managed care. Another point of significant discussion was around accessing data. When approaching state Medicaid offices to expand guidelines-based care, the state Medicaid office might request state-specific evidence that coverage of guidelines-based asthma care will actually improve outcomes and lower costs. We heard this many times throughout these conversations, that really nailing down any data you have around outcomes and costs are particularly important to Medicaid. The evidence can come from a variety of data available through a number of sources. So Medicaid's claims data, maybe you could analyze Medicaid data to help tell your story to the Medicaid office if you have that available to you. A number of local initiatives, so grantees certainly already had programs ongoing and have evidence related to their ongoing programs to share with Medicaid. So some of the self-reported data we heard was very important. Bringing managed care organizations and whatever data they're willing to share to Medicaid was noted as a very useful strategy, providing evidence and data on the efficacy of guidelines-based asthma care through that MCO delivery model. It was also noted that data from MCOs can be challenging, that oftentimes it's considered proprietary and folks don't want to share it. So we had one grantee in particular have great success with their MCO, but others noted that that was quite a challenge. And then finally, the 618 initiative. We heard lots of very helpful things about 618, finding that the value in participating in CDC's program, 618 initiative, was very helpful. As you know, 618 connects teams of state Medicaid and public health department staff with CDC researchers, economists, and other analysts to promote best practices. And I would say, universal agreement from the grantees that participation in 618 was just very valuable as they helped craft their messages to Medicaid. In terms of collecting data, as noted earlier, trying to present compelling data can make the case for coverage. As Medicaid considers issues related to cost and quality, it might be particularly interested, for example, in data related to hospitalizations and associated costs, emergency department visits and associated costs, outpatient claims, the asthma medication ratio, which is the performance measure currently being used, and then the self-reported health outcomes. But again, big emphasis on return on investment and cost savings. Those are the sort of magic words to speak to Medicaid programs. Grantees shared best practices about making a strong case to Medicaid for coverage of guidelines-based care. They emphasized the need for a really good, strong working relationship with Medicaid staff at multiple levels. That there is some turnover that happens often within the Medicaid office, and really trying to network and strengthen relationships at multiple levels was important. Grantees described their meetings with Medicaid staff to date. For example, they described their meetings as often being briefer than they anticipated, that you had to be very flexible as you go in. You might think you're meeting for an hour, and they might just have 20 minutes. And that these meetings really, the individuals favored in the Medicaid program favored well-defined and well-supported plans and requests. In other words, don't go in asking for a long list of requests, but think about how to narrow that list to 1 or 2 actionable items, and be very specific with that request. Grantees talked about the need for a flexible plan. You might go in thinking you're going to make a specific request, and after hearing Medicaid's interests and feedback, you might need to pivot and turn and adjust your request to meet what's also of interest to the Medicaid program. Good discussion from the grantees about how to mobilize internal allies, trying to decipher who within the Medicaid program can help mobilize work around asthma guidelines-based care, knowing individuals are important, and a big push for making sure that your pitch is short and succinct, being clear and brief and bringing data to the table to support your request. And then finally, the need to maintain that communication once that initial meeting is over. Grantees discussed the importance of developing a data use agreement with Medicaid. Grantees reported needing Medicaid data about program performance and patient outcomes. This data use agreement, if you don't already have one with Medicaid, it grants access to data related to the need for and potential benefits of coverage of guidelines-based asthma care. Grantees noted that a data use agreement should be negotiated early on, that having access to that data is very important in terms of monitoring ongoing work and any evaluation you might do later on. There was quite a bit of discussion about how difficult claims data can be to collect and analyze, and the importance of having that Medicaid claims analyst or specialist, very important to the efforts of the grantees. One grantee noted that Medicaid in one case provided a Medicaid claims data analyst to assist with identifying, obtaining, and analyzing the data, and that also Medicaid analysts had offered to help train some of the health department staff, which was really welcomed. Another grantee used a university-based expert to help with data analysis and really gives quite a bit of credit to that relationship in terms of advancing their work. Grantees shared insights about implementation of services. Planning for implementation once the coverage is actually granted can help avoid roadblocks. Of course, early planning has significant benefits. Grantees talked about the need to create a roadmap, and many of the grantees found it very useful to sort of map out their plan by using a specialized tool. We've provided, I think, a couple of examples of those in the appendix. The role of quality measures came up quite a bit, and the need to really stay on top of quality measures generally. Medicaid and CHIP currently measure the quality of a child's care by the asthma medication ratio, or AMR. This is designed to measure a child's level of control over their condition based on their medication use and, by extension, the quality of asthma care they receive. The grantees noted that a piece of legislation in 2009 called CHIPRA included provisions to really strengthen the quality of care provided to kids enrolled in Medicaid or CHIP, and that CHIPRA introduced and invited states to voluntarily report on a set of performance measures called the Child Core Set. Beginning in 2024, all states will be required to report on the Child Core Set of measures to CMS. So this was very much on grantees' minds as they are working through whatever performance measures they're currently using as they look to the future. Finally, ensuring that data collected is useful to the analysis of the program. Accessing and analyzing Medicaid claims data is really vital to evaluating your program, needing to be accurate and timely. But the grantees did discuss limitations to this administrative data, including requiring large administrative data sets, data management, data integration, and data quality. And then finally, we heard about a number of barriers experienced by grantees that they faced when trying to implement guidelines-based care for asthma. They noted the need for a robust trained workforce to deliver asthma-based guidelines care, including folks like community health workers, certified asthma educators, environmental health specialists, and others. They talked a lot about how certifying guidelines-based asthma care providers under Medicaid can actually take significant training and vetting and, actually could require new policies or workforce development infrastructure. For example, in states without a certification process for community health workers, legislation may be necessary for these providers to be recognized and eligible for reimbursement. Another barrier discussed by grantees was establishing sufficiently high rates for reimbursement to implementation that can help encourage providers to bill for services. Rates are oftentimes too low and without negotiation and demonstration of the potential ROI. So, for example, in one state, reimbursement was as low as $250 per hour for 2 home visits, and grantees noted that that was challenging. So I'll just say that while barriers were definitely noted by grantees, I think the grantees remain very optimistic about their collaboration with their Medicaid offices overall and the progress they are making as NACP grantees. With Hannah, I'll turn that back over to you.
Great. Thank you so much, Katie. And again, to everyone, if you have questions for Katie, feel free to type them into the Q&A box now so you don't forget them, and we will take all of those questions at the end of today's presentation. So now that we've gotten an overview from Katie of some of the key findings from the report, I want to turn now to talk to 2 of the state asthma control programs who have been really at the forefront of this work. And so first we're going to hear from Peggy Gaddy, who is the Missouri Asthma Program Coordinator. Missouri has really been a leader in states across the country looking at improving Medicaid coverage for patients with asthma, and has really gotten very far along in the journey towards implementing guidelines-based asthma care for the Medicaid population. So really excited to hear from Peggy today and learn more about the work that they're doing there. So Peggy, let me turn it over to you.
Thank you. Okay, Eric did have to leave, so he's not going to be speaking, but I'll go to the next slide. Okay, we've had a very bumpy, curvy road to reimbursement for asthma care support services. We did go the state plan amendment route because when we did this, about 50% of the state was fee-for-service and 50% was managed care. So we had to do a state plan amendment if we were going to cover that 50% fee-for-service. And in order to get that done, we used state-specific data. And we had partners in that with the University of Missouri and their Asthma Ready program, and they had grants that helped us with funding to analyze the data. And also the thing that I can't stress enough is when you look at cost data, you look at the total cost of care for those asthma patients. Don't just look at the cost of asthma services, because when you start providing the services that are guidelines-based, the cost of asthma services may go up, but the total cost of care for that patient will go down. So always make sure you look at the total cost of care and not just asthma charges. And spas take a lot of time. It took about an 18-month course of action to advance this option. So when we say take what you can get, we did try to negotiate, and we highballed, lowballed, and we ended up with a pretty low reimbursement. But I think another thing in hindsight, Medicaid figured out how many patients they thought would receive these services, but our services can only be provided in the home. And when you start talking about getting into someone's home, that greatly diminishes the number of clients you may have. So I think that's something that needs to be taken into consideration when you get your cost per client. Is it going to be what Medicaid really estimates it to be, or do you have some information that says, no, I think it's going to be about 25% of what you're estimating, so I think that we can be reimbursed at a higher rate. Managed care companies, we can make change with them without having to go through a SPA. One of the things that we did learn when managed care became 100% in Missouri was that you can get people credentialed through Medicaid, but that doesn't mean that they're credentialed through the managed care organizations. So we have 3 in Missouri, managed care. So that means that you've got 4 organizations that you've got to try to get your provider approved to provide the services. And I know that's small in comparison to like California and other states that may have 30. So that's another thing that you've got to think about. Just because Medicaid says they're okay doesn't mean the MCO is going to say they're okay. So when we approach the MCOs, we approach them with, how can we help you? How can the workforce we've developed help you meet your quality metrics? And another thing that we did was, when we knew also in the middle of all this, all of our MCOs, their contracts went out for bid. So we asked Medicaid to put into their RFP the asthma clause that said they had to provide the services that fee-for-service provides. Because if you don't do that, it may not be where the MCOs have to provide it at all. So always think ahead about that. Some of the things that we've also passed in Missouri is the Health Home program. And we've got asthma, children's asthma as a standalone qualifier for the Health Home. And normally with chronic disease, you have to have 2 or more chronic diseases to qualify for the Health Home. So we were very proud that we got that done. This also improves enrollment in the clinics and outreach service capacity. And it also increases the provider interest in risk identification and referral for asthma support interventions, self-management education, inhalation instruction, home environmental assessment. Return on investment and risk stratification are your friends. Risk stratification is critical for allocating services and controlling fear of cost explosion related to adding new services. And local data and experience is essential for estimating a believable return on investment. Do y'all have a blank screen now?
No, Peggy, we can see the stacks of work slides.
Okay. So that just tells you in Missouri, I can see it up in the little slide, but it's not showing up on the big area for me. So the stacks of work show you how we have tried to, and this was created probably 5 or 6 years ago. So this shows how we can show how everything that we do relates, the environmental assessment, the home education, all that kind of thing, you have to have all of those pieces to actually impact the care of the pediatric patient. Oh, it did go really quick past there. So I've also changed the next slide, shows you a website that we created to try to link school nurses to managed care. School nurses can help refer your clients for asthma education and home environmental assessments, and so it's really important to involve the schools because they're the ones that see the students every day for usually 8 hours a day. And so we created this website to help improve communication between school nurses and the managed care companies. The MCOs, Medicaid, the School Boards Association, the School Nurse Association, all of them were involved in creating this website. And it'd just be something that you could go out and look at in your own time. And that's all.
Great. Thank you so much, Peggy. That's really, really helpful information to learn about the great work that you're doing in Missouri. So I'm now going to turn it over to BJ Biskupiak, who is the program coordinator for the school health and asthma control programs at the Montana Department of Public Health and Human Services. And Montana is similarly going through the process right now of trying to get reimbursement for guidelines-based care in their state. And so I'll let BJ talk about some of the work they're doing and what they've been learning. BJ?
Great, thank you. Glad to be on the call. So like you said, we are still in the process, so we're not quite as far as Missouri there, but we are. We're hoping to be there soon. So over the past several years in Montana, we have been working with our Montana Medicaid partners to secure reimbursement for asthma home visiting services. And I'll just share a little bit about our process and where we're at now. So we knew that we wanted reimbursement for asthma home visiting services, and we knew of other services that were offered by the Department of Public Health or other partners that had worked with Medicaid to make that happen in the past. So we had some initial discussions with our partners in Medicaid, which in Montana it's easier to do than some states, I imagine, because Medicaid is part of the Department of Public Health and Human Services here. So although we're very separate in our chronic disease bureau and we're kind of siloed out, we do have them within that department, so we can get those meetings set up fairly easily. So like I said, we already knew from our data. We kind of looked at our program data, and we knew that home visits, our home visiting clients saw dramatic drops in emergency department visits, unscheduled hospitalizations, and urgent care visits. And we also knew that families who completed our home visiting program, and we'll call it MAP is what we call it here, so we'll just use that acronym going forward. So MAP, they experienced less symptoms and fewer missed school days and fewer missed work days. So we had that information, but we had to really focus on what was important to Medicaid. So, ultimately we decided, that's cost or the potential cost savings. So we went back to our MAP data and analyzed that for participants who listed Medicaid as their primary insurer. And right now we're actually currently in the process of matching up Medicaid clients with their claims data to determine kind of those long-term impacts of the program as well. So that's another piece that we're still working through, but we do have at least their data from the program itself. So what we were able to do with that was create some resources showing the burden and making the business case for this reimbursement. So as we compiled the data, we also thought about different options for reimbursement, and in turn, hopefully the expansion of MAP here in Montana. What we looked at were kind of two options, and one was opening billing codes, and then the other was pursuing a federal match through either FMAP or an administrative match. So those were kind of identified as the best options. And throughout that whole process, we did participate in at least quarterly meetings with Medicaid just to stay on their radar, usually more frequent than that. But as I'll discuss later on, we did run into some resistance just with their priorities and different things coming up on their agenda as well. So in 2018, we began to receive support from the CDC and the Centers for Healthcare Strategies through the 618 initiative. So that was a big help as we kind of compiled the information and put together different documents throughout this process. One thing that we did that was pretty important was just organizing the information in a format that was most useful and helpful for our Medicaid partners. For us here in Montana, that was kind of just a decision document. I'm sure it's similar in other states, but just the format's probably different, but just the information they're looking for is probably pretty similar. Some of the big things that they really wanted to cover in there were just kind of the summary of the proposal, the statement of need, some examples that have worked in other states. So that's where we've been able to reference Missouri and Rhode Island and other states as well. we also just laid out the current status of asthma home visiting in Montana and those results, and then kind of identified our different routes that we could take and our recommendations there. So the tips that we have that we've kind of gleaned from this process, we found it very helpful to align our messages with and our requests with Medicaid goals and objectives. And we found that making home visits widely available and sustainable really aligns closely with a variety of their goals. So they have 5 kind of main goals in Montana Medicaid, and we hit 4 of those, and that's the 4 big ones that they have are promoting health equity and improving population health. Another is ensure all children and youth achieve their highest potential, and then effectively engage stakeholders and ensure core business services are efficient, innovative, and transparent. So we felt that what we were asking here really aligns with at least 4 of their 5 main goals. And so just to be able to approach them in their language has really helped. So what we've also, I kind of mentioned this a little, but just really clearly stating how our proposed changes will help Medicaid achieve those goals. And then what we found to be important as well was involving the high-level decision makers in the conversation. While we did have frequent meetings, a lot of those meetings early on were just with some of the Medicaid staff that were helpful, but and helpful getting the conversation going. But when we really needed to make decisions, we had to get the director in the room with our state medical officer and with our program managers to really move that conversation forward. We also had to decide early kind of how they'd like to receive that proposal, and I talked about that decision document. It had gone through a couple of different iterations before that with different staff turnover, so just making sure that we know early on but what information they're going to want. And then a big one for us was really to be aware of current Medicaid priorities and challenges. Some of the, in Montana, some of the biggest challenges there were just as we went through Medicaid expansion, that was kind of a big topic. It was going through our state legislature early this year, and so Medicaid was consumed with that, and pretty much any other proposal, no matter what it was kind of pushed to the back burner, including ours as well. Excuse me. So along those lines, they also had some staff turnover there and different challenges. And now that Medicaid expansion is in place in Montana, or that it continues, they have to come up with a plan. They have to come up with their budget, and they have to implement that. And so they still have a lot of different priorities, and it's hard to just fit in there. But as long as we can help them see how we can help save Medicaid money in the long term, then we can kind of get in with them and kind of align with those priorities as well. So I had mentioned that we had participated in the 618 initiative. So through this, if other states haven't participated in this, you really do get a lot of technical assistance. There are webinar opportunities around making the business case, public health funding, Medicaid delivery and different payment systems, and then just different financing options and covered benefits. So that was really helpful for us as we thought through different funding mechanisms. And a few of the other things that we had received there as well were kind of bi-monthly calls with the CDC and Centers for Healthcare Strategies experts. So they really helped, whether it was reviewing our decision documents, providing some technical assistance on different language that they felt Medicaid would respond to best. That was very helpful for us. They also those partners also helped us think through those different funding mechanisms that we hadn't considered, like the administrative match or that FMAP. And then they also provided examples of strategies in other states and got us in contact with our counterparts in other states working on similar projects. And then we also participated on calls with our Medicaid staff and asthma control program staff, where those partners were able to kind of help facilitate that conversation, so we didn't get bogged down in some of the details we didn't necessarily agree on. And then just to circle back to some of the challenges that I've mentioned a few of these, but again, those competing Medicaid priorities, legislative session was big for us, that kind of turnover, and then for us it was hard to get Medicaid, and it's still a little hard to get Medicaid to really look at the cost savings long term, no matter how much data we show them, and how much ROI, how clear the ROI is. It's just getting them to find the budget for it up front, which has been a challenge. And then for us, we've also ran into some issues with just lack of staff and resources, where we may not have had an epi for an epidemiologist for some time. So it just took a little bit longer for us to kind of get in-depth cost analysis and return on investment information. So some of those things can just slow it down, but we're at this point we're pretty positive. We're still the conversation's still moving, but we do have to kind of wait on Medicaid for the time to be right, and hopefully in early 2020 we'll be looking at working on a SPA that will get asthma home visiting services covered to some extent. Whatever the final decision is, we're hopeful that that'll go through in early 2020. That kind of wraps up our project, and I'll pass it back to.
Thank you, BJ. It was, again, really helpful information. Really appreciate you sharing that with everyone. So I'm just going to spend a couple minutes going through some of our project resources, but once again, we're going to move to Q&A in just a couple of minutes. So feel free. I've already got some great questions, but feel free to continue to type those into the Q&A box for all of our great speakers. So before we get to there, I just want to quickly make sure that you all are aware of the other resources that we have through the Asthma Guidelines-Based Care Coverage Project on our website, which again is lung.org/asthma-care-coverage. So each year, as I mentioned earlier, we release new data on state Medicaid coverage of guidelines-based asthma care in every state. So you can go to our website now. We released our new coverage data in June, and you can most up-to-date information for your state, where the coverage gaps are, what barriers there may be, and you can also look at nationwide coverage maps that we have on our website as well to sort of compare where you're doing in your state to other states across the country. If you are interested in doing a deeper dive into our coverage data, we did a webinar releasing that data last month, and so that is archived and on our website, along with other webinars that we've done on other resources. We have a great one on self-management education on there, on different tools for stakeholders working on guidelines-based asthma care, so I encourage you to check those out as well. And then, of course, we have the new report that we issued today, as well as other fact sheets and issues on topics related to guidelines-based asthma care on our website. So definitely encourage you to check those out. Two resources that I want to highlight today, just to get based on the topic that we're talking about, are a couple of other documents that we released earlier this year that really focus on working with Medicaid. So the first is a primer on Medicaid managed care in asthma. So as you've heard today, especially from Peggy, where managed care is a bigger become a big part of Missouri's Medicaid program. depending on your state and if there is managed care in your state Medicaid program, really understanding how that works, how that can impact asthma coverage, understanding some of the different terms and language, as Katie was talking about earlier, can be really important. So we have just a 4 or 5 page document on our website that provides kind of an overview of Medicaid managed care and how it impacts asthma coverage. So depending on your state, if managed care is a big player there, that can be a helpful starting point. And another thing that we have on our website is just a short 2-page handout that looks at the return on investment of guidelines-based asthma care. So one of the things you were hearing today was how some of that cost and economic information can be really important to present to Medicaid when making the case for guidelines-based asthma care coverage. And so earlier this year we released a fact sheet that has some kind of key talking points in that area, along with, based on a literature review that looked at recent studies just in the past 5 years on the return on investment of guidelines-based asthma care coverage, especially in Medicaid, but we also looked at private insurance and some other coverage areas as well. And really some of the key points from that were certainly that coverage of guidelines-based asthma care reduces healthcare costs for payers, that multiple programs have been able to show a positive ROI in Medicaid, and has some really great examples of some programs around the country and the ROI that they found. We can see that adherence to evidence-based care results in improved asthma management and better health outcomes. And then finally, that Medicaid recipients currently face multiple barriers to guidelines-based asthma care, which can reduce the opportunity for Medicaid to see some of the economic, and cost improvements based on coverage. So again, those are just 2 of many resources we have on our website that I wanted to highlight since we're talking today about working with Medicaid, but really encourage you to check all of our resources out. Again, lung.org/asthma-care-coverage. So with that, I think we will move to Q&A. So we've already got a number of great questions coming in. So let me start. We've got a couple of questions about the asthma medication ratio. So Katie, let me maybe start with you to sort of, I know we mentioned that in the report, just maybe explain to folks again what exactly that is and why might Medicaid in particular be interested in programs and any change in the AMR that they show.
Yeah, so as I mentioned earlier, this asthma management ratio is designed to measure, the level of control over a child's condition based on medication use, and by extension, the quality of asthma care that they're receiving. It is currently the measure that's being used, the primary measure. There was quite a bit of discussion about the inadequacy of this measure and the need for the development of new measures. And I wonder maybe BJ and Peggy, I don't know if you all have additional information you'd want to share as having to collect data around this.
Well, we do look at that. We look at the ratio of inhaled corticosteroids, how much they're taking, how many times a day, or how many times per week. And we also look at the rescue medications to make sure those are going down. So that's going to come about many times when you do the environmental assessment and you improve the environment. You may see kids that were not improving on high doses of the inhaled corticosteroids, and once you fix a sick house, then they begin to improve and may get their inhaled corticosteroids decreased. So those are things that we do look at as far as education and environmental assessment to make sure that those improve or get better. Or they have better adherence is what I should say, yeah.
Great, thanks Peggy. So another question that we got, and Peggy, I think this is probably for you as well. Do school nurses need sort of prior approval to get the home care referrals covered by Medicaid MCOs in Missouri?
See, that's the thing with fee-for-service. You've got to have prior approval from physicians. And we've just now begun to delve into what the MCOs are going to require, but I don't think that they have to have prior approval. So there may be a way. We're actually going to go meet with them next week to get all of that clarified. but we think that they can pretty much make the rules that they need to make to get their clients taken care of. So I can tell you more about that at a later date.
Great, thanks, Peggy. Another question that we've received, I think, BJ, this is coming based on some of your comments. Do you have any advice for how to get high-level decision makers involved in the conversations? Any tips that you have from your experience in Montana, BJ? BJ, you might be on mute.
Oh, I'm really sorry. I had to step away for just a second. Can you repeat the question? I apologize.
Sure, no problem. Just a question about some of your comments about the involvement of high-level decision makers and how did you get those, and do you have any tips for getting those involved in this conversation, getting them interested in this issue?
Well, for us, I guess a tip for getting them involved. For us, it came down to getting all that information put together and the kind of the highlights of it, the bullets of it, the shortest version. For us, it was that decision document, but keeping that short and really highlighting what you wanted them to know, and then having that come from kind of our high-level staff as well, bringing in that state medical officer if you can, bring in department director as well.
Great, thanks, BJ. And this can, I think, really go to any one of our speakers. Just a general question, when you, especially as you're moving sort of towards implementation, are there things that you wished you had thought of earlier in the process that, sort of looking back, you wish as you were at sort of the beginning stages you had started planning for earlier?
This is Peggy. One of the things I wish we'd planned for earlier was looking at what the process was going to be to get people qualified to provide the services. We had no idea it was going to be that hard of a process. And so we were so worried about getting the spa done and getting the partners on board that once it was done, then we figured out that it was going to take a while to get all the bugs worked out of getting people qualified to be providers. So that was something we did not look at up front. And I think it could have saved us a lot of time in implementation and getting the workforce ready to be reimbursed.
Great, thanks, Peggy. Katie or BJ, anything you want to add to that?
This is Katie. I think we did hear from all of the grantees that even as you begin to approach the Medicaid office, even for the first time, to not wait to think about what implementation might look like, but to try to think ahead and begin to do that strategic planning. Don't wait for the decision from Medicaid, but really move forward thinking through those details early on.
And this is BJ. I would agree with that. We're lucky enough to have a lot of that infrastructure in place just with our home visiting program, and the way that we're hopefully going to get this passed is that it would, that home visiting would be covered through our sites and under sites that are trained by our program. And so we're lucky to have that in place, but if you don't, just really thinking about that, who's going to be implementing it and doing that. I agree, it's nice to set that up ahead of time if you can.
Great. Okay, I think we've gotten through most of our questions, so maybe just one final one I'll throw out to all of you is, are there any, key partners that we haven't mentioned or you just really want to stress that were sort of really important to engage early on?
This is Peggy in Missouri. We actually worked with the Asthma and Allergy Foundation. We started out as we were going to be just do a pilot project in St. Louis, and it was just going to be environmental assessments. Then when we met with Medicaid, they said, no, we can't do pilots. We need to do the whole state. And then they brought in the asthma education, and things just kind of grew from there. And then the director of Medicaid said, I want data. So then we went back and got the data on return on investment, because we had implemented an asthma education program with school nurses. So we had already gotten that information and just had to do a comparison to students who had not participated in the project, so we could show the cost savings there. So, and then we had the information nationally on the home environmental assessments. But the Asthma and Allergy Foundation was instrumental in getting it started. And they got a legislator on board as a champion. So that made it a little bit easier for us to talk to Medicaid. And then we turned it, Medicaid kind of took it over, and they decided the partners that were coming to the table. And we were a key informant and we were a key partner, but they wanted mainly the hospitals. They wanted to talk to the hospitals. That was what they considered to be their key partners.
Great. Thanks, Peggy.
The children's hospitals, let me go back, because ours only cover children.
Great.
This is Katie. I was just going to add and agree with what Peggy said. I think, what we hear oftentimes from Medicaid offices as they consider new coverage decisions, they really want to hear from providers. Physicians, hospitals, they want to hear how it impacts their patients. So I would just highlight that that's certainly a key partner to bring in with you.
Great, thank you all. This is another final question I will answer, is that we've gotten some questions about the recording for today's webinar. That will be sent out to everyone who's on the call today. Everyone who registered will get a link to that as soon as it's available, and we'll also have it posted on our website, again, lung.org/asthma-care-coverage. So I think with that, we will wrap things up for today. Any follow-up questions, feel free to email us at asthmacare@lung.org as well, and we're happy to try and assist you. And really, once again, just want to especially thank all of our speakers. Really appreciate your time today, and hope that you will find the report, this new report, helpful in all of the work that you're doing. So thank you very much, everyone, and enjoy the rest of your day.